Welcome everyone, and thank you for joining us on this April Fool's Day. But this event is not an April Fool. We've called it this close to Easter because the government announcement on Monday about the public health reforms made clear that they're expecting feedback by the 26th of April, so there's not far to go. We've got a stellar list of speakers to give their initial perspectives on the health reforms. So if you can move to the agenda now. I'm going to introduce, then I'm followed by Maggie Ray, President of the Faculty of Public Health, Paul Burstow, who has had many hats in his life, but is currently independent chair of the ICS in Hertfordshire and West Essex, as well as chair of Tavistock Mental Health Trust, Hazel, Cheeseman, Director of Policy at ASH, and David Buck from the King's Fund. And we'll then do Q&A at the end because there's quite a lot of overlap between different presentations, and we felt that would be the best way to do it. I should make some comments on how we're running today. So we are tweeting, and the hashtag is #TransformPublicHealth. Can we move on to the speakers brief? So we've asked the speakers to address the following questions from their perspective: the opportunities and risks, strengths and areas of improvement of the current system, conditions required for the new system to succeed, and what should be reflected in the next iteration. What is it most important for people to focus on in their response? Can we move on to audience questions and comments? So to ask a question, please use the question bar in the panel at the right-hand side of your screen. If you open that up, you can send us as many questions as you like and as soon as you like. I mean, do send questions during the presentations. You don't have to wait until right at the end, because otherwise we risk getting just so many questions when the question session starts that we can't coordinate and group them. And with over 100 participants, I'm sure you realise that we'll have to summarise and group people's questions. We want to hear your comments too. Just add them to the chat and or tweet using #TransformPublicHealth. I am now going to hand over to Maggie Ray, who many of you will know, is President of the Faculty of Public Health, but also has a major interest in health inequalities and has worked at all levels within the system. Thank you, Maggie.
Thank you very much, Deborah, and thank you so much for organising this important event today. Could I have I've just got a couple of slides I'd like to show you. So could I have the first slide, please? So I thought it would be useful while I speak to have this graphic in front of us about the new public health system in England. And I suppose I want to present today and answer the questions that Deborah has set out for us, but also to give you a mix of the positive messages, but clearly we want to focus also on the challenges and the potential risks of the new public health system in England. So we've now heard the announcements about the setting up of the UK Health Security Agency, the separation of the health protection functions in the English public health system to this new agency from what previously existed in Public Health England. And yesterday we had a further announcement about some of the destinations of the other functions of public health. So this is a situation where instead of having all the functions at the national and regional level in one agency, we now have them spread to the Department of Health, NHS E&I, and the setting up of the Office for Health Promotion. There's quite a lot of vagueness about the regional Director of Public Health role. Certainly in the engagement with the advisory board that was set up by the Secretary of State, we had specifically spent quite a lot of time on the importance of ensuring that the public health functions work together seamlessly to be able to create a new system of public health in England that has ensured that we have a strong local system, a good and strong regional system, and a national system that can work seamlessly together, both in terms of responses to pandemics, but also for some of the really other important issues like health inequalities and tackling the other wider determinants of health, as well as some of the prevention issues. And I didn't want us to forget about academic public health. Academic public health is a very important area and function. And again, these changes haven't radically affected academic public health, but it's an area that needs strengthened, and we'll be looking to the new system as to how we ensure that academic public health is strengthened through this process. But as you imagine, the devil's in the detail. So probably the good news from the Faculty of Public Health perspective is that we presented government and the people involved in the redesign with a functions and standards document that represented what we saw as excellence in public health. And we probably have the best training systems for public health in the whole of the UK. And we want to make sure that that doesn't get diminished through these changes. And I'm sure we could spend quite a lot of time unpicking what wasn't perfect about Public Health England, but the separation of the health protection function from the other functions is a major concern, and something that we need to spend quite a bit of time on the system design that allows us to build back together and make sure that we can function together. So could I have the next slide, please? So in answer to the specific questions, what are the opportunities and risks of the proposal? So when the announcement was made in August, without any consultation and without any real engagement, the decision to disestablish Public Health England, it would have been possible, I think, that we may have lost many of the functions of public health. So I suppose from a good news perspective, are all the functions of public health protected in these new arrangements? So checking through the list yesterday of where people are going, I think on one level we can say that it seems to be agreed now that all the functions of public health will find a home in the new system. So the challenge is, how do we join them up? How do we make them function effectively? And whether we took the examples of sexual health disease or the examples of trying to manage TB, probably every single communicable disease, and we've certainly seen it through the pandemic, through COVID-19, has an element that affects the other functions of public health. You cannot look at communicable disease in isolation. And so we probably start with a deficit in the model that we've got this separation now. And some of the areas of strength, I think, through the last 15 months is that the directors of public health are now much more prominent. They're centre stage in the world of public health. And we have seen considerable investments coming into public health. But is the money getting spent in the right way? It was quite shocking to me that we were spending, well, I think now the total's up to £37 billion on the test and trace system, and yet we don't seem to have been able to spend that kind of money, anything like that kind of money, even a couple of billion on local public health. And you will not have a strong public health system in England unless your local system is able to deliver. And I know David's going to talk more about the funding, so thank you for that, David, because this should be a resource that is equally distributed based on need to the local regional and national systems for it to function effectively. And I think the conditions that we need for the new public health system to succeed is to have a way of influencing into the future. And so I think it will be important to know whether there's going to be a board, an open board, to govern some of these arrangements. And I was very pleased to see the recognition from the Minister that we should have a committee to oversee the outcomes, the future health outcomes that we're going to deliver and have a reach across government. Certainly when I led on health inequalities at the Department of Health in the time that we were able to narrow the gap in health inequalities, a lot of that was because we had very big influence on the NHS and very big influence over other government departments. So I think it is good that we have an opportunity now to build a department of health that truly can look at prevention and public health. I think that was one of the deficits of the 2012 changes. But again, there's the whole issue of independence and having an independent voice. And I don't necessarily believe that Public Health England was able to have that voice. So I think it's very important that there's a clear line of sight to the independent voice of the CMO and make sure that there is a distinction between the political arrangements and the evidence base and the ability to speak truth to power in the public health community, both at the local level, regional level and national level. So those are the kind of conditions that I think we have to see into the future, and an openness and a transparency about where the funding is being spent in relation to public health. And then just on the last point, what should be reflected in the next reiteration? Well, I'm particularly interested in what's happening to the role of the regional directors of public health. Through the transition period and the engagement of the stakeholder group, we spent quite a lot of time talking about the regions, and we were assured that the regional function role was going to be there to pull the whole public health system together. So we could link prevention, we could link health improvement, we could link healthcare, public health to the health protection, the new health security agency and the health protection elements of public health. And the two things that I think still concern me a little bit are, how is that going to work? There is not enough visibility in the documentation to give reassurances at this stage. I think there needs to be more system design for us to understand how that's going to work. I think we also need to be really concerned with issues like dental public health, screening and immunisation, and certainly screening and immunisation destination looks like it's going to the NHS. And we need to make sure that we can join that up with all the health needs work, the behavioural change, all the things that we need, and link that to the local directors of public health. If we don't have the local system, there will not be changes in health outcomes, and health inequalities will just continue to get wider. So those are very, very important issues, I think, for all of us. And then we've seen, as I say, the investments going to the national team, not necessarily through the whole system. And I'll finish there. Thank you, Deborah.
Thank you, Maggie. That was brilliant. I think that's a really good way to kick the event off. I just want to say that if anyone has comments or questions coming out of Maggie's presentation, do put the questions in the question box and add to the chat, and do feel free to tweet hashtag transform public health. The thing I forgot to say to people is that if attendees suddenly lose audio or have other technical difficulties, the best thing to do is to leave and rejoin. And if that doesn't work, email admin@smokefreeaction.org.uk and we will do all we can to help. I'm now going to move on to Paul Burstow, who has many hats, including being a board member of ASH, for which we're very grateful. And Paul will give his insights both as a former health minister, but also someone who had years of experience prior to that in local government, and who as a chair of an ICS has an understanding of the evolving health and social care landscape. So I'll hand over to Paul.
Thank you very much, Deborah, and thank you very much for the opportunity to contribute to this this webinar, and very timely indeed. Like Maggie, I'm going to try and respond to the questions that you've posed, I think more or less in the order that you posed them, and start with the question about sort of giving some thoughts on the opportunities and risks. And I think what I would start to say is when one reads the paper that's been published, I try to look at these things with the lens of optimism rather than being negative about it. So I took great heart from the quote in the paper that health is no longer the business of the Department of Health and Social Care. Now, some of us would say that's always been the case. Some of us would say that that has been an absolutely essential part of what government needed to do for a very long time. But it helps that it's been said in this policy statement. And I think one of the things I will say at the end of my contribution is that in future iterations, I think there needs to be further elaboration of how that laudable intent is translated into practice. And I'll come back to that in a moment. I think my starting point in thinking about the opportunities and risks really is set by the white paper that was published back in February, the white paper that outlined the government's plans to move integrated care systems onto a statutory footing, and the way in which it articulated that change as being two forms of integration: integration within the NHS and integration between the NHS, local government and other partners. And I think we have to explore and unpack that in terms of how it plays against this set of proposals that the government have made for the architecture of health promotion and the overall infrastructure for public health, both nationally, regionally and locally. I think I'd particularly point up the statement in the white paper and the intention, I presume, that this will be in the legislation, that integrated care systems will have a new set of purposes compared to the purpose articulated traditionally for the NHS. And those purposes are not just to improve and deliver healthcare, but are to improve population health. They are about tackling unequal outcomes and access. It is about, obviously, the perennial agenda of enhancing productivity and value for money, but it's also recognition in the white paper about the need to support the NHS to give its abilities to supporting that broader social and economic development at both place and system level. And I was struck in the press statement that was issued in support of the policy paper and this announcement around this new health promotion function within the Department of Health, the reference to something which many on this call will know only too well, that the proportion of people's health outcomes that relate to health care is very small, and indeed that acknowledgement that 80% plus comes from other causes. And I think that that sort of focus on the social determinants that's talked a lot about in this paper has to be grasped by system leaders like myself as a license, as an authority to act, and to act and challenge traditional ways of thinking in terms of how we design and implement the health and care systems that integrated care systems are to be at the heart of. And I was really struck by something that the Secretary of State said at the Local Government Association conference very recently, when he was asked about the public health grant funding. And I absolutely agree with the points that Maggie has already made about the adequacy, or rather inadequacy, of that funding. But it was interesting that he said that his goal was to ensure that the whole of the NHS budget in a local area, alongside the budgets that local authorities choose to put in place, should be brought to bear on this agenda. And I think that has potentially profound implications and huge opportunities if it is more than a rhetorical statement by the Secretary of State. And I think one of the things that in feeding back on this draft is to call out how that might be made a reality, because it does beg some questions about how do we make a reality of health in all policies. I think it also picks up on the point that the Secretary of State has talked about, which is seeing the NHS and local government as equal partners, something I absolutely believe to be a correct thing to say. But being equal partners means that as equal partners respecting one another, there will be uncomfortable conversations between the partners about how we genuinely fulfill the new purpose of integrated care systems, particularly tackling inequalities, particularly tackling and addressing population health. And I think that does mean serious debate about how we use our budgets, both the NHS budget and local government budgets, in that way. And I think that is both a risk and an opportunity. And I think the biggest risk I see in all of this is that the behemoth that is the NHS and the day-to-day pressures of dealing with restarting treatment services to catch up on backlogs will limit the bandwidth that is available for the NHS part of this partnership to be able to think about how it plays its part in serving those 4 objectives I was talking about just now. And I think that sort of risk that the accountability conversations that integrated care systems will be having with the NHS will be at their most pointed on those most politically sensitive issues around dealing with backlogs, rather than on these long-term important changes which we need to make to affect population health over time. And I think what we need to say about our local government colleagues is that we also need to learn, they need to be learning from their peers about how they make sure that the very best of what local government does is something which we are seeing in all places. I think, again, that's part of that uncomfortable conversation that needs to take place within integrated care systems. I said 2 types of integration just now were what the white paper talks about. But I think there is a third type of integration, and that's integration in some parts of local government to embed and integrate public health in all aspects of local government. I take that as being part of what this paper talks about. And I think the risk is that we do just focus on the tip of the iceberg in terms of the public health grant, rather than the totality of the public spending that is available across public agencies at a place and system level. And I do think that this is an opportunity to really push the Secretary of State and the government in responding to this paper about how those things are made reality through system working. I was also asked to say something about the strengths of the current system and areas for improvement. And I absolutely think, as one of the people who advocated for public health to return to local government when I was a minister, that it's been the right thing to do, that becoming, again, part of the local government family and having that distributed leadership of public health across the country has actually been a strength and a part of the resilience during the last 12 months, only that it was made better use of, perhaps, as I think Maggie has said. And also, I think there is that opportunity to really influence all aspects of local government responsibilities. In some places that's been done very well, in other places there's still more to do. And I think when it comes to the question around this shift that I'm talking about, and which I think is critical to delivering the white paper, do you see the whole council as an agency for population health and wellbeing improvement, or do we just locate it within our public health function? And I think it's that mindset which I think is part of the debate that we are having. And nationally, Public Health England, as Maggie said, was an agency. It took its brief. Every year there was a letter from the Public Health Minister to the agency, basically telling it what was expected of it. So I can't help but feel that in the last few months, it has been thrown under the bus as a convenient distraction from others' accountabilities and responsibilities when it comes to the discharge of responsibilities during the pandemic. And indeed, over the last 5 years, it has been very successful at integrating a very splintered public health architecture particularly in England. And I think we need to consider ways in which health and wellbeing boards have functioned across the country as well as part of our infrastructure for public health and wellbeing. It's been highly variable. And I hope that we, as we move forward with these reforms, will be looking again at what the lessons of the best of health and wellbeing boards are, so that they can be learnt and shared. Just to say a little bit about the role of the region, and again, I would echo some of the comments that Maggie has made, how they add value and amplify capability. In other words, how they act as integrators across their region to facilitate and strengthen the public health voice in all decision making, I think is an important part of their role. How do they support peer-to-peer learning and peer-to-peer challenge within the public health space and beyond it? And how do they call out the opportunities, as I've said at the beginning of my remarks, about how we leverage the whole public sector budget in a place to this purpose around improving population health? And just maybe to end with a few comments about conditions for success, and just a couple of final comments about next iteration of this government paper. I think there are 2 or 3 things I would say about conditions for success. I think first is that both NHS and local government need to be encouraged and allowed to use the permissive elements in the policy intentions set out in the government's white paper, and indeed in this discussion paper, to construct and co-design a public health and population health approach that goes beyond tactical approaches to population health and really is systemic in its approach, really addressing those issues that Maggie was talking about just now. And that does mean being able to look at the whole budget. It does mean looking at the whole public sector workforce and how all play a part in these ways. And I think it also does mean recognizing that the infrastructure of public health has a cost. There is a cost of opening up the shop, if you like, that has to be funded to make sure that we have highly performing, well-functioning public health right across England. And I think Maggie's comments about the levels of investment here is absolutely right. And then my final comments are about the next iteration. And I think I would say there are 2 or 3 things. One is the ability of the new agency and its relationship with the department to be able to speak truth to power. And I think here, strengthening the CMO's role is absolutely critical. And I think there's needs for more detail here, both for the CMO, but also in terms of his role across government, and needing to build that in terms of the relationship even with the Treasury, who ultimately have the ability to influence so much of this. I think one piece that's missing from all of this is a recognition around the vital importance of social infrastructure. We've seen the pandemic wash much of the foundations of our social infrastructure away because it was already weakened after many, many years of underinvestment. We've seen real challenges to the resilience of our voluntary and community sector. And I think those need to be acknowledged because they are key elements in a successful population and public health approach. And I think understanding the costs of a fragmented national architecture does need to be explained. How are they to be mitigated and how are they to be aligned? I think finally, the move to integrated care systems over the next 12 months is going to be a very time-consuming and bandwidth-constricting activity. And there is a real risk that the business of doing that will prove a distraction from addressing the agenda that we are here talking about today. And I think therefore part of the feedback to this paper has to be that this has to be mainstreamed as part of the move towards integrated care systems. Thank you, Deborah.
Thanks very much, Paul. That was really helpful and very complimentary to what Maggie was talking about. I'm going to hand over now to Hazel, who's Director of Policy and Action on Smoking and Health, but is not going to be speaking just about smoking. We've been having discussions with other voluntary sector organisations working across the modifiable risk factor area, so mental health, obesity, alcohol, sexual health, and also colleagues in localities. So I'm going to hand over to Hazel to try and reflect our thoughts, our initial thoughts from a broader perspective, recognising we're not going to cover everyone's concerns.
Deborah, can you see my slides? Deborah?
Yes,
Yeah.
we can see them.
Yeah, okay, thank you.
Yeah.
So I am, as Deborah said, I'm going to talk about the impact of the reforms and from the perspective of the modifiable risk factors. And so I should say this is an ASH perspective, but it has been informed by discussions with stakeholders from some of these other sectors, from mental health, alcohol, obesity, sexual health, and from local government as well. But you know, any errors are mine alone and they're not responsible for them. So I just wanted to have a reflection at the top about what it is that we want to see from our public health system. I think some of this has been picked up by others, but you know, it's really important that we have a system that can help deliver us robust evidence, can deliver the impactful policies we need to secure changes in the population's health, that can deliver and facilitate effective policy implementation, and can, as Maggie and Paul have touched on, can deliver this wider action from all other parts of government and across the tiers of government to support the improvement in health outcomes, and that we can evaluate and monitor progress. And I don't think there's any magic formula or any magic system that would automatically deliver this sort of excellent public health system. But the job I think we need to do in looking at this consultation is to assess to what extent does the system that's being proposed bring us closer to delivering on some of these things. And so that's the framework I'm going to take forward. So I'm going to start by talking quite briefly about the new UK Health and Security Agency. From the kind of modifiable risk factor perspective, this is probably not the lead agency, but it's obviously a really important part of the future system, and obviously has relevance to kind of key risk factors. So, you know, it's really important that there are strong links around the interdependencies and a strategic understanding within UCSA about the importance of these modifiable risk factors. To give an illustration from the pandemic, you know, the importance of the impact of the pandemic and the lockdown measures on mental health, you know, has been absolutely massive. And taking those sorts of things into account as we're developing strategy around health protection is vital. And you know, these are, you know, strengthening those links and making sure they're not lost, which both Maggie and Paul have touched on, is going to be really important. So the question for the kind of consultation response from our point of view is how can UCSA take account of the issues at the heart of the Office for Health Promotion, you know, embed the ideas around addressing health inequalities and those key risk factors in the way that it is approaching the world. And the other thing, and again, I think this speaks to what Paul was saying around, you know, bandwidth in the system. You know, there's going to be, you know, they're going to have a key relationship to local government, to NHS at regional and local level. And there is a risk that it becomes it's the big new agency, that it becomes a centre of gravity, detracting from all the other things that these stakeholders need to deliver on. So there's a real challenge going forward, both, you know, as we have NHS reorganisation and reorganisation across the health promotion and health improvement parts of public health, that there's enough bandwidth left to look at the really important things about these modifiable risk factors that really determine much of our health outcomes. So I'm going to talk in a bit more detail about the proposals around the Office for Health Promotion, which is clearly where much of the activity around the modifiable risk factors is likely to be delivered. So I've pulled this really long quote, and apologies, from the document, because it's really interesting in terms of its ambition and the direction of travel that it suggests from the policy note. You know, that it talks about government having a responsibility to go further to protect the public's health than just sort of information provision, and that it identifies these situations in which government needs to go further and do more around protecting children and the most vulnerable, where there's a risk of disease, the risk of disease is shared across society, where there's a disproportionate burden on the NHS, and where government action is needed to tackle significant inequalities. And then this one at the end, which I obviously is particularly, you know, mentioned smoking, is particularly relevant to our agenda, which is around addressing the power imbalance that might emerge from industry behaviour, and it talks here about industries based on addiction, like smoking. So, you know, there's a real sense of the broad ambition of government to intervene and improve the public's health. But there are other parts of the policy document that people have identified which, perhaps appear to have a narrower focus, to focus more on kind of information provision, changing individuals' behaviours, and not quite to represent the scope that seems to be here in this quote, or indeed in some of the other commitments. And there are other stakeholders out there who have a real vested interest in promoting this idea of a narrower vision for health promotion. Here's a quote here that was in the Telegraph from Chris Snowden, who works for the Institute of Economic Affairs, who received funding from the tobacco industry, among others. And it talks about a much narrower vision for the Office for Health Promotion. He, in my view, quite rightly says there is an appetite among the public for health improvement. But then perhaps erroneously says that this isn't around, these more these wider approaches to tackling risk factors like alcohol, tobacco, and obesity. And he talks about, that this agency acknowledges somehow that there is a difference between public health issues like COVID and issues like obesity, and that COVID justifies what he describes as coercion, and that obesity doesn't. I think, I wouldn't agree with his characterization of coercion, nor would I agree that the public appetite is not there for taking a broader view of health improvement. Certainly the polling work that we do suggests, and this year we've looked not just at tobacco, but also at alcohol, obesity, and at gambling, and there is strong public support for policy measures. The public understand that the health is determined by a much wider set of reasons than just healthcare, and they seem to support measures that would go further. But there will be an alternative narrative out there about what the future Office of Health Promotion should be, and it's to us and to the job of this consultation response and the work going forward to reimagine what health promotion might be in this moment, post-COVID, when the health inequalities have been so laid bare, where the public is certainly behind the need for us to do more to have a healthier, more equitable society, that we need to seize that moment. So I'm just going to reflect on what else seems promising to us from the policy paper and from our discussions with others. And as has been mentioned, the strong and independent role of the CMO is a positive output from this, and hopefully we'll be able to boost the capacity to provide independent advice. This is something that we certainly want to see safeguarded as the plans are developed. The emphasis on wider determinants, which appears throughout the policy document, is again certainly to be welcomed. And then this links directly into the commitment for cross-government working through this ministerial group. This sense that it's everybody's business. This is really, really promising narrative and direction of travel. And then we have this kind of twin thing where we have an Office of Health Promotion that has some sense of coherence and a standalone identity, but is much closer to the Secretary of State than Public Health England has been located within the department. And there will be opportunities that come from having both that retained coherence, but being closer to the centre of political power. There's some interesting discussions in the document about the developing options around an incubation function for public communications on these key issues like smoking, obesity, and other things. And that's going to be absolutely crucial to retain the ability to speak to the public through mass communications on some of these absolutely crucial public health issues. And then there's also a commitment in there to improve data linkage, which is not very exciting, but is very important. So just to think about what we will be taking forward in our consultation response. So I'm not going to talk a lot about public health funding, but it's an absolute given that it has to be sustainable funding going forward and sufficient funding going forward, that we need something that is stable and meets the needs of the whole public health system. The document talks about having a new public health strategy, but it's not something that we can wait till the end of this process to have. We need it alongside the new system. And I think in having something, a comprehensive public health strategy as we're developing our new system, it perhaps will help to mitigate some of these risks about being distracted over here by NHS reorganisation and distracted by the creation of a new health health prevention entity, that having a strategy about what we will deliver will help to focus as we develop this new system and give it a sense of purpose and ambition. And that strategy and that strategic approach and the way that the new system is built, needs to be the full range of possible policy levers, not just this, narrow, perhaps, the past idea that we've had of what health promotion might be, just handing out leaflets. That's certainly not going to be a radical way of improving the public's health. It needs to be the full range of options that are out there. There's a real question mark over what role civil society is going to play in this new system. It's kind of nodded to in places, but fleshing that out in more detail is going to be important. Civil society has a lot to offer the new public health system at every tier. And what will the document is very, has this idea at the beginning around the sort of power imbalance of industries that put the individual's health at risk. But there is little in there about how we will protect policy development from those industries and really take that forward. I'm just going to finish by a few thoughts about what the document has to say about the local system. It quite rightly acknowledges that the local system has been developed significantly over recent years, and that COVID has made it probably even stronger. So it says here, we want to build upon these strong foundations and further support and strengthen local public health systems and their leaders. And the question that we need to take forward in responding to this consultation is, what are the tangible things that can be done to strengthen and support local systems? And there is a massive opportunity here. I think Paul and Maggie also alluded to it. One of the impacts of COVID, and as many of you listening, I'm sure will know from your own experiences, is that the role of public health has become so much more important within local government and within the local system. Directors of public health have, visibility and influence that they perhaps haven't had in the past. So seizing that moment and that opportunity seems really important. And from our experiences and our conversations with local government, they are more proactive, generally speaking, in embedding the idea of public health across local government in different departments and thinking about it in a creative and broad way. And it's possible that local government really has something to teach national government about how to do this cross-government working, cross-departmental working well. Paul talked about this as well, this notion that there should be a partnership of equals at local and regional levels around local government and the NHS, particularly through the ICSs. This consultation response is not the only place in which this idea needs to be fleshed out. The development around the white paper and the legislation that will come around ICSs will also be really important. But how to make this a reality so it's not a tick box exercise to include local authorities, so that there's genuine influence across the system and that we can take a broader perspective beyond healthcare to the local to the ICS view of the system view of health. It also talks about the opportunity for additional powers for local government, and this would be a really great opportunity to look at where some of those wider determinant opportunities are. There's been much discussion around a public health objective within licensing that could really help to empower local government to take their public health role forward in thinking about, for example, where alcohol licenses are given out, or indeed, looking at where fast food and so forth is sold. So there's lots of opportunities to think about all the other bits of local government and what their contribution is to health. And I really encourage people to think about the creative opportunities that we could suggest local authorities be empowered to take forward, not just within the sort of strict public health remit. And the RDPH role, the Regional Director of Public Health role, is described as having this really important convener role in the system. But there is, going to be a challenge here in that they have to straddle the NHS, health protection and health improvement, and making sure that they are able to have a coherent leadership across all three of those areas, and it's not, they're not pulled away from one or the other, is going to be really important, and that those are individuals that can play that convener role and be resourced to do so. I think that's my last slide, so I will stop there and hand back to Deborah.
Thanks, Hazel. just to remind you, do put your questions in the question box and any comments in the chat box. I think that was very helpful, Hazel, pointing out that the proposals can be interpreted in different ways, and what we want to do is to turn the really positive shoots, green shoots one could call them, in the policy note and the public announcements from the Prime Minister and Secretary of State for Health and CMO into action to make the transformed public health system that we all want. And I'd like now to hand over to David Buck as our final speaker, Senior Fellow at King's Fund, who's been working in this area for many years. In fact, just before the event started, I was talking to him about some work he was doing in the 1990s when he was at the University of York as an academic working on public health issues. So I'll hand over now to David.
Thank you very much. Thanks for reminding me for that. That old. The danger also of going last, of course, is that lots of things have already been said which you agree with. So, and I'm reminded that actually the brief times that I get to speak on platforms with Michael Marmont always come after him. So I feel a bit like that in the sense that a lot of what I agree with a lot of what the previous speakers have said, and will reinforce some of that, I think, from my perspective, and maybe say a couple of other things. Also, Paul, I think when you started you pointed out that particular quote at the LGA ADPH conference about the Secretary of State seeing actually the white paper and the integration agenda as the route for the NHS to push all its resources into prevention and around public health. I was also very struck by that, and actually that's the sort of title of my blog, which is probably coming out later today. And I wish I'd had this conversation with all of you before I wrote my blog, but it does pick up, this is the blog at the King's Fund, does pick up some of the issues that we've heard. And so I think I'll probably reinforce some of what people have said, and then maybe say a couple of other things. But I'm really keen that we get onto the Q&A so that you hear less from us and we hear more from you, and we can have a conversation. So in that spirit, I think one of the really strong opportunities in this is actually bringing the expertise of PHE closer to the centre of government decision making, as others have said. And I think a cynic would say, and sometimes I can be cynical, that actually we're just rebadging PHE, which is an executive agency of the Department of Health and Social Care anyway, so they're all civil servants in PHE, and we're just changing the label on the door. But I don't think that is true. And I think the point also that was made about actually PHE, given it is every organisation has strengths and weaknesses, one thing it did do is the public health, I think, world was fragmented before PHE, and it's brought that expertise together. One of the challenges, Maggie has said, is actually we're pulling some of that apart. Nonetheless, the expertise that particularly I think will go into DHSC around the Office of Health Promotion is a really strong, coherent sort of people and knowledge and expertise and connections. And if that can actually be really focused and brought to bear on the whole of government policy, the whole of government agenda, and that is successful, that is an absolutely massive opportunity. So the challenge is, how do we make that successful for me? But that is a real opportunity. So I think that's brilliant. Obviously, there's also downsides to that. We've heard of some of those already. One of my concerns is the loss of transparency and openness, as also others have said, that actually one of the strengths of PHE is that it has been open. It has got its website. It's got all its data and intelligence. There's a challenge about how do people use it? Are people already using it? But it has been much more, I think, open and transparent. It has actually talked quite and put the money behind things like minimum unit pricing, which for alcohol, which wasn't necessarily popular amongst politicians at the time. So the key thing for me is that it still manages to do that as it disappears into or that it doesn't disappear into DHSC, and that we maintain that transparency and we see that outside of DHSC. And that also gets back to what others have said, the role of the Chief Medical Officer and others in this. For me, it's really great that the Chief Medical Officer has a stronger role. Well, maybe a risk, maybe if too much too much investment in an individual. So what we also need to see is a very strong team around the chief medical officer, and the chief medical officer reaching out, as we know he does. So it's the team around him and the authority of those around the chief medical officer, as well as the investing in the person themselves. I think there's also a great opportunity here to align with the white paper, particularly as Paul was focusing on. And I was again struck that that seems to be what's in the Secretary of State's head around this. But what we need to do, and I'm leaping ahead now for the next iteration of focus and maybe our responses as a community, is to make sure that that we say that this alignment needs to happen, that the white paper on integration that follows on from that really needs to put the effort behind public health and prevention role of that, and as we all know, does not get sucked up into just the elective backlog type issue, which it will do if there are efforts not to do that. One of my also slight concerns is that again, that by a lot of the push on the cross-government agenda at national level, that we lose some of that local focus. So I hope that that isn't the case, and I support what others have said about the role of the regions and the regional centre. And I think that's something that needs definite strengthening, and for many reasons, including those that other people have said. For me, there's something about actually we need a very strong regional public health function, so it can bat as an equal vis-a-vis the integrated care functions, the integrated care systems in the NHS, and not just the NHS, sorry, but that's the whole point, within and with integration within and without the NHS, but to actually be a big partner in that. And the other thing for me, which some people do disagree with me on, is I think we need to strengthen accountability for public health across the system, and that includes locally and local government too. Now, I know that that's not always popular, but I do think one of the real challenges, and it moves back to what Paul was saying too, was around actually how can we really ensure that the best of the best is done everywhere. And I don't think that, I think sector-led improvement is great, but I'm not sure that it's sufficient in that. So I think what I would be looking for in the next iteration is a stronger sense of what does accountability for public health and connected population health outcomes really look like in the future public health system, and how does that connect to the white paper, what we're expecting from integrated care, and that becomes much clearer than it is at the moment. It's very, to my mind at least, as an outsider, it's very, very muddy. It's very unclear. You follow all sorts of strings and not sure where they end up. And so I would really want to see a stronger focus on that. And I think the regional role is really important there, not just around accountability, but also around system improvement and support. So we need to reinvest in system improvement from the centre as well as from local areas. And we've underinvested in system improvement, and we can learn from the past in this. And Maggie is my predecessor. We sort of had the same role at one point. I think there's a lot still to look back on about how the focus on health inequalities in particular across government worked up to 2010. Not that we can replicate that, but how can we, this is the option, how can we bring back some of the learning from that into this current system? And so that's as much about system support as it is about performance management. I think you would expect me to say that a condition required for success is real political will and leadership, wherever that politics plays out, be that regionally, nationally, and locally. I also think the experience of COVID has really established, if it were needed, the role of directors of public health. We've been doing a really humbling piece of work following some directors of public health over time during their experience in COVID, and we can see just how valued and the authority that has come with their experience of COVID, but also the real personal toll that has taken on them. And so I see great opportunity for directors of public health in the future, even more so than now, but also what a huge potential burden we're placing on them. So we need, actually the system needs to support them. They need greater authority, they need greater funding, they need investment in the teams around them in order to make the most of that. And so what I worry about is that actually we're asking too much too soon. So we need to work with this really skilled resource and support it as the new public health system starts to emerge around it. You would expect me, as Maggie said, just about funding. I mean, I'm sure I don't need to go too much on that, but we need to, basically the cash needs to follow the determinants of health in this new system. And at the moment it doesn't, and that's really clear. So we've, you know, whilst we had these new announcements, we've also just had the public health budget, the core public health grant announcement for 2021-22, which is a £45 million increase over 150 or so local authorities. It's notwithstanding what we've also had, which is COVID money, which is, I think, has been very, very gratefully received in government. But I'd also echo Paul's saying, you know, we've had, depending on how you measure it, you know, 20–25% cut in real spending power in local government since 2010 or so. So we need to put that right. So the challenge for the Office for Health Promotion is how can it actually influence the Treasury? That's the government department that needs most influence in this. And how does it talk to the Treasury? But beyond that, I think there's a real opportunity there's win-wins here across government, and the Office of Health Promotion can actually can offer expertise, all that expertise we're talking about, which is coalesced around PHE. If it can offer that to other government departments, secondment, say, actually, what can we do for you to help you meet your objectives? And along the way, you'll help meet health objectives too. I think that's the way to go. So there's something about the tone and the offer, as well as asking the rest of government for to do things for it. On that, we've had experience of that too. Maggie was saying about the experience up to 2010. We've also had the Public Health Subcommittee, sort of relatively short-lived subcommittee under Andrew Land, under the coalition. So we need to learn from the experience, and Paul would be obviously great at this. What works in terms of these bodies and what doesn't? How do they need to be set up? How do they need to act? How do they need to cohere? What we don't want is just a talking shop, and that's the risk that I've been in. When in my career, I've been in lots of cross-government committees, which are basically just talk, or supporting them at least, which are just talking shops and about alignment. Alignment is great, but we need, what does this ministerial cross-government, what power does it have to actually change things? Where's the teeth? So that's what I'm going to be looking for in the next iteration. We need that detail. Actually, how is all this stuff going to work? So I've probably said more than enough and reiterated some things that others have said. I do think there are real opportunities in here, but we need to be mindful of the pressure and the experiences of all of the people that we're talking about, including those in PHE. The great thing is they have more certainty as staff members, which they didn't have until very recently. We need to be mindful of the pressures and concerns that people are under because of COVID and everything that's related with that, as we seek to help design and influence the future. So that's probably enough from me. Thank you very much for bearing with me.
Thanks, David. And if all the speakers could bring their pictures up, that would be helpful, because we're going to start the Q&A session. I found that really useful, but there's an awful lot to get to grips with, and there are a lot of questions. But I think, can we start with where we ended on cross-government working and how it can be made to be most effective? I mean, one of the things I think is very impressive about local government during COVID is how they have worked not just on the COVID agenda, but broader health inequalities agenda across local government, with support from councillors and other departments and the voluntary sector. And that's been incredibly impressive at a time of emergency. But how can that happen at national government? And how can the Treasury be engaged? And I'd like to ask Maggie and David, first of all, from their perspective, having worked within government previously, and then go to Paul on that question.
Shall I start, David, and then come in? Because I'm kind of convinced that Paul is the better expert here, but for what it's worth, we'll give our views. I mean, when I started the journey on the strategy on health inequalities, I think it was fair to say that I think the government had lost its way, and I think no one was paying the blindest bit of attention to the health inequality targets, the performance indicators for health inequalities. And I think my long-standing view is, unless you're thinking about something every day and it's part of what you're actually delivering every day, it will not happen. And I think we talk a lot broadly about health inequalities, and we're all terribly interested in it. But when you actually examine yourself, I mean, is anyone here actually working on obesity? I mean, I know Ash is working on smoking. That's one thing we can always guarantee, that every day, Deborah, you, Hazel, Paul, and the whole Ash team will think about smoking every day. But I'm not convinced everyone really thinks about health inequalities every day, other than a sort of ethical view. I think you need to get into the delivery. So I think what really worked for me was finding some narrative that is so compelling that people have to buy into it. And even politicians need narratives. And I think also, I would never underestimate the power of the Treasury and the Cabinet Office. When I started the journey that David then took over and followed up, I mean, I virtually lived in the Treasury for about 6 months when we did the review of health inequalities. And I remember Liam Donaldson saying to me that he was very worried we were going to lose the life expectancy and the infant mortality targets because they just hadn't delivered. They hadn't shifted at all. And so unless you get into getting people to know that it is achievable and there's a simple set of actions that you have to take, and you think about those actions every day and you follow up those actions, because the reality is most interventions, however well-meaning, actually widen health inequalities, because it's always the better off populations that take them up. And I reviewed the fluid data, and there's a complete parallel universe and an incline to the most affluent have taken up the option and the most deprived. You could do it with the COVID jab, you could do it with any intervention. So I think getting the compelling narrative, and I think we've got the narrative as good as we had it when we started the strategy that narrowed the gap. And I think we could do it again. But we have to get into the Treasury. I mean, as I say, I virtually decamped to the Treasury when I was doing that strategy. The Prime Minister's delivery unit, as it was at the time, were on it. The Cabinet Office was on it. And they then committed to delivering it. I think that's what it needs, the commitment of others, including politicians, to want to deliver it. Thank you.
David, can I ask you to talk about what you think the key narrative is to engage the Treasury? And then Paul, what mechanisms might be made to make it work?
The irony is, sorry, that I'm actually speaking to the Treasury a bit later on about this very. So I'm really hoping. So I'm going to take what Maggie's just said and also what Paul will say, and hopefully use some. But I completely support what Maggie said. I think for me, my experience was one, actually having, and I know there's always challenges around choosing the right metrics, having a clear metric that you're working towards, which is broad enough to engage lots of partners and narrow enough to know whether you're going to hit it or not, or work towards it. My experience, and again, this is all going back, my experience was quite hard in government because just like we were probably going to miss the target. Nonetheless, it's such a galvanizing thing. And I think actually having, what is the metric? What are the metrics? And we haven't talked about this. We have the ONS health index that is being developed. We have life expectancy with healthy life expectancy. For me, there's something about actually we need to challenge particularly the NHS to say, you've really got to deliver on inequality reduction and amenable mortality, and you have a massive contribution to make in your local system with your ICS, with your local partners on things like inequality and preventable mortality. So we have the metrics. For me, there's some choices to be made. I'd also include in that this small set inequalities in tobacco use, etc. Inequalities in the experience, prevalence, severity of multiple long-term conditions. But there are a small enough set that I think we need to cohere around. I think what's different now, which I think is interesting, is we have I hope, and this is what Paul thinks of this, we have potentially a much stronger regional systems that can own some of these things themselves with some support from national government than I think we probably did have back in the day when I was in the Department of Health. So the locus of control and power is shifting, I hope, regionally, and the regional bit, you know, then can connect to the local and then back up to the national. And that's what, again, why I think many of us think that the regional role for public health is really critical, so that it plays a really strong role in that. So how would Paul's ICS own metrics like that? How would they compare themselves? How would they look to the national government? So I think the locus of some of this stuff is shifting, but the critical thing is have the metrics there to agree them, and you're all partners in delivering them, and you're transparent about it. And then we have the evidence arrayed, which a lot of which was created under Maggie's time, a little bit under my time, but it's still there. It's still in the system. But the thing is, it's not connected to the accountability. So that's why, for me, accountability is really critical at wider government level, but also coming down the system. The other thing about you talking about the treasury, I think the thing is what's the win-wins? You know, I know it's easy to say and hard to pull off, but there are lots of win-wins to be had. What is it that by working on health inequality, on public health, we can actually provide what you want to achieve too? So being much clearer about that, and that's where, for me, the cross-government ministerial group comes into play. But I also hope that ministerial group has power and is not just a conversation piece, because I think that's the other thing. What power does that group have? And I guess that's probably where I might hand over to Paul to sort of to get his views on things like this, and particularly in its relationship to the Treasury and where the money goes. Because I think the other thing is, you know, the cash has got to follow the determinants of health, and that's where we're not at the moment. So I'll end there and hand over to Paul, because I'm really interested in what he's got to say.
Thank you, and I think that point about the cash following the determinants, I think is a really helpful formulation, which does, I think, need to feature in some of the sort of ongoing influencing and dialogue around how to land the changes that the government's setting out. Just to sort of speak to the cross-government piece first, I think these work best when there's a very clear mandate from the Prime Minister. They work best, I think, when you have the Treasury absolutely in the heart of it, because if the Treasury isn't in the heart of it, the Treasury is going to be the first obstacle to actually delivering stuff. So I think there is something about, should this be chaired by a health minister, or should this be chaired by a minister who actually looks at spending right across government? It's open for debate, but my preference would be to say it should be chaired by a Treasury minister, but with their remit including this wider sort of role around population health. Because actually they're the ones who have difficult conversations with every government department about how they're delivering on their spending. Part of that conversation by a Treasury minister should be through this lens. So I think that for me, and I think the other piece is how the Office for Health Improvement is positioned as being part of the Department of Health, but actually an agency for the whole of government. And again, I think the way in which that is landed within the civil service, as well as within the political sort of cadre within government, is absolutely essential in terms of the sort of advice that is submitted to ministers in other departments. So nowhere are we going to see, I should see the rapid scaling up of this to be able to contribute to every submission that goes to every minister, but helping to skill up civil servants to have this lens when they are drafting submissions to every minister is something which should be an explicit expectation set by this cross-government committee, that they are expecting that to be how it works. So those would be my sort of two or three things there. And I think the other things I would then just reflect on some international experience. And it's still evolving, I think, in terms of this example. But back in 2019, New Zealand was one of the first governments to publish what it described as a wellbeing budget. You know, the intention was bigger than the execution of its first go at it, but it nonetheless was saying that we were going to apply wellbeing and health improvement as key tests to all of our spending. And I do think that has to be part of the ambition here, if you're genuinely to follow the money to follow the determinants. And I think the other couple of things I would just say about the role of region and sort of point that David was talking about in terms of the local context. Again, I think we have to work through the way in which combined authorities are changing the landscape and think about how they relate to the regional structure as well. I think the last point I would make is that we still have a fragment, to the extent to which the department still produces outcomes frameworks for different parts, it still silos them. We need an integrated outcomes framework set by government that does bring together the sort of social care ambitions and outcomes, the public health ones and the health ones. Because if you don't have that, and this is my last point, in the oversight framework that's now being laid out for consultation with the NHS around integrated care systems, the five national themes, only one of them talks about preventing ill health and reducing inequalities, but it's very much through the lens of just the long-term plan. And yet the ambition that this policy document talks about is bigger than that. So I think there's something quite urgent about making sure that that national theme is not just scrutinising from the point of view of the NHS deliverables, but actually this wider ambition.
That's a good point, Paul, but I wonder as well how far those health related and social care related outcomes frameworks need to reach out into other departments as well. So, if you look back to public service agreement, PSAs, there were, agreements for other departments that related to their health objectives. Is there something there we need to think about? So it's not just about the NHS and health and social care, but actually about how that fits with other departments' priorities and their priorities as well. Going back to what David was saying about, levelling up and how public health and reducing health inequalities can contribute to levelling up.
Yes to all of that, and that really was why I made my comments about the machinery of government at the beginning, because I think it is fundamentally about how you rewire the machinery of government to make sure that what will still be a relatively small agency within government close to the Department of Health and the Secretary of State and the CMO has that ability to be an agency that informs and influences effectively the way in which the whole civil service advises ministers.
Thank you. I'd like to go on to a very different question which has come in around how can primary care be more involved, because a lot of the talk about ICS, the NHS long-term plan, is all very secondary care focused, and local government is, local government. So what about primary care? Does anyone want to answer that? Maybe Hazel, I know you've been looking at this for hours, but in a broader context. Have you got any thoughts about this?
Well, other than the fact that it seems pretty challenging. I mean, again, I think it's probably back to the role that ICSs are going to play in terms of system leadership. And we've been looking at how to better support the emerging primary care networks around health inequalities, obviously specifically tobacco. And it's challenging to see where the opportunities are nationally to do that. I think they have to come from system leadership, which is going to be delivered through ICSs. And so I think, again, we're going to go kind of circling back on common themes. How are we going to make sure that the prevention framework is there for ICSs to see that as part of their role in relation to primary care, and to have sufficient priority on this to be able to bring primary care into play, because there's obviously a massive role for primary care to play in addressing all aspects of this, but it's quite challenging to really bear down on primary care and get them to change their activity so that it kind of better meets the needs of the prevention agenda. And it seems to me that we're going to have to do that locally, or at ICS footprint, rather than trying to find the national levers to do that.
Deborah, can I just make a quick contribution on that very briefly?
Yes, please.
I agree with everything that Hazel just said, but I would just add the only part of the NHS, as far as I can see, in terms of the white paper, that will not have the new triple aim duty placed upon it will be primary care. And I think that either through the GP contract or through the contracting of primary care networks, there needs to be an explicit reference either in the contracts or preferably in legislation, so that there is that alignment of expectation around population health across all the elements of the health system. And the other thing that is currently missing, which we need, I believe, is an accountability framework for PCNs in terms of what they will be, in a sense, accountable for and accountable to for that. And that's still missing in the architecture. ICSs will have a responsibility, but without a mechanism to have accountability for it. And that needs to be fixed, I think.
Another question that's come in is around how we can ensure that the priorities aren't just the priorities of individuals within the system, whether it's the CMO or RD's PH, and how far it will be top down and needs to be in both directions, so bottom up as well as top down. I think that speaks to your points about accountability in both directions, David. So I don't know if you've got thoughts on that.
This is really hard. It's not easy, and there's no perfect answer. I do think there needs to be that overarching goals which the national system sees as critical. I do think the public health outcomes framework was a great thing, actually, because it's pretty comprehensive, but it's manageable. So there is something about, can we, and notwithstanding what Paul said about the integration of those frameworks, actually, how do we sort of mobilize that framework to be picked up and used more in an accountability sense locally and regionally? It's a really tricky question, but I do think that we need some overarching things that we all agree we're working towards, which national government is working towards too, using the existing sets. I mean, we've been doing, but there's got to be ownership regionally and locally too. It's really tricky. So I haven't got a really simple answer to this, but we've been working with Greater Manchester and to some extent the GLA Health Committee, and some of that all got knocked off track because of COVID, of course, but around these sorts of issues. But how do you cohere a set of indicators that make sense to you in your system? And then, because we're the King's Fund, we then aligned them around our population health framework, saying, you know, why the terms health are critical, integrated health and care system is critical, behaviours are critical, and community is really critical here, and about community strength. And if you can array your indicators across, and these all interact in a sort of Venn diagram, at the centre of this you have your overarching goal, which could be something like healthy life expectancy, because it combines very well, or at least to some extent, both morbidity and mortality, etc. And then as you radiate out, you've got goals that really contribute. I mean, indicators or metrics really contribute to that, but which you can only deliver if you've got really strong partnerships. So the NHS has to play its role, local government has to play its role. You have to give invest in community to deliver this too. And so you get an array of sort of slightly smaller, a small set of indicators which you're all cohering towards. And then as you go out around those circles, you say, oh, actually only the NHS can deliver that, so it should be accountable for it. So I think making some sense of that, having some national framework, some national support with some really key core indicators, and then that supports actually in your regional system, the balance between these may be different, but these are a reasonable set that actually makes sense for all of us. Your balance is different. Who delivers that, how you do that, how you bring in primary care, you have that great knowledge. But let's try and link the data to the partnerships in order to deliver. And I think for me, that may be the way to go. That will look slightly different in different places, and it probably should, but they cohere together in some form. That's easy for me to say, hard to do. I think, you know, some of the really forward-thinking ICSs are already thinking about this, so it's nothing novel, it's nothing new. But I think that's one way to try and get that sort of that coherence between metrics, indicators, the national, regional, local, and between sort of contribution. So that's where I might sort of say that might be fruitful, learning from what we've done in the past as ever.
Can I come in? There's been another point raised about we need to be careful to avoid just shifting national responsibilities to localities. And an example was raised of the fact that every local authority spends an awful lot of time on alcohol licensing with an unfit for purpose national act. And earlier the point was raised that maybe there is a role for public health as a licensing objective. But are there other opportunities that any of the speakers can think of for strengthening the national framework to help local delivery, whether it's in the NHS or local authorities?
I just come in very quickly, and I'm no expert on this or much else, but I think, you know, planning regulations and roles is an area, you know, planning and public health and place shaping, and there's been lots of efforts on that, and it feels to me there's a massive opportunity there, how we shape the environments around us. And I know LGA have been lobbying for a long time for changes in that area, and so really gripping that. So again, how can the Office for Health Promotion actually bring in the expertise, and there is expertise in PHE and around PHE on planning and health? How can that really be driven across government? You know, healthier planned environments. You know, really critical area for me. Lots of change that's required, but that's a real opportunity too.
Does anyone else want to lob anything in at this point?
Can I come in on this one, Deborah? I think this is taking us to a health and all policies place, where actually we do need health and all policies, but more importantly, we need to stop the adverse effects of policies. Whether it's, you know, we won't deliver this if everything's just down to individuals. We do need individual programs to support individuals to take those healthy choices, or, you know, whatever the phrases are going to be in the future. But we all know that that isn't enough, and that's sort of blaming the people responsible for their own ill health. It doesn't work. So it needs to be a mix of that responsibility, but also that we have good legislation. And that's why I favour health and all policies. And we will be speaking later on in the year about spatial planning and how important planning is. And that's been one of the advantages of directors of public health going into local government, to be able to really deal with some of these local planning issues. But we need national legislation where national legislation works. And I hope there'll be an appetite for some more national legislation on public health to strengthen what we've got, and to, you know, part of our job is to advise government about things that we would like to see that would make an enormous difference, and engage all government departments in that. If there's legislation in any government department, we should be advising on that from public health. But I also want that to be matched by the Treasury. And so I do think there's an opportunity from Matt Hancock's speech, where he announced, when he was asked about following up questions about where the resources are in public health. And we do have a lot of resources getting spent in the NHS, but across government. So I think we should be asking for, it wouldn't even be 1%, colleagues, it wouldn't even be 1%. It'd be less than 1%. It might even be 0.1% of every government department to be spent on improving the public's health. And certainly a percentage of the NHS spend, particularly with the money that's going to be in the ICSs. And I think certainly in guidance, if it's not in legislation, we have had fantastic engagement. I think it's important to say where things have worked well. Fantastic engagement between public health and the white paper team on ICSs. They've really pushed the boat out, a very good example of engagement. And we've managed to get into the guidance, and it came out in the policy paper for public health, that local directors of public health would be involved directly in both boards for the ICSs, the partnership board and the ICS board itself. Of course, we need to leave local people to decide how that's going to work. But I think that does give me confidence that a health and all policies and a health and all the plans for ICSs and any other government department functioning is there and checked for the health impact on the population. Thank you.
Thanks, Maggie. I'm going to go to my last question now, which is to go to each of you to say, how optimistic are you about the future of public health following these announcements? So shall I start with Hazel? I'll call you out so you don't just stand there thinking, oh, shall I go now?
I feel more optimistic after this conversation. The potential, you know, I feel like we've really drawn the potential out of the reforms in our discussion as much as we've identified the pitfalls. I know if we can secure an ambitious prevention strategy which sort of draws together the discussions we've been having about metrics and accountability, it's sitting across government with specific actions, health in all policies kind of approach with a commitment to funding, you know, what's to hold us back? I think the experience of public health in local government over the last 12 months has been challenging, but just so much to be optimistic about and to be kind of awe-inspired about what's been achieved over the past 12 months. And there's a moment to build on that with the public support. You know, we can see public really support action in this area at the moment. So yeah, I think there's definitely reason to be optimistic, and we just have to seize the moment.
Thanks, Hazel. David.
I am too, and I guess for two reasons, but one caution, which we've already said. I mean, I think we've learnt an awful lot, and I do think there are opportunities. I think we actually have a quite existing. We haven't talked about health and wellbeing boards very much. I know Paul mentioned them, but I do think we have actually quite a lot of the structures that if we really work with them and use them to their greatest extent, we've actually got all the architecture that we probably need. You can always add a bit more, and I think particularly with the political will, with the experience of hopefully coming out of COVID to really push things, I think I am optimistic. I guess the challenge, I think, is again something that Paul said, was actually we'd have to try and avoid being pulled back into just the elective backlog from the NHS's side. We have to maintain the vision, and I think that's down to all of us actually, who can actually help maintain that vision and make sure it pushes through into the future. And I think, frankly, keep our eyes open and keep talking about stuff, and take the opportunity to really engage with the people who are designing policy at the centre and see it as an opportunity, because I do think it's there to be grabbed, notwithstanding all that we've said about was this the right time to do it. I think there's a real opportunity there, and I do think there's the framework to really make a difference, but we need to keep pushing.
Thanks, David. Paul.
Yes, I think I am optimistic, but I think the key thing now will be in its execution. That's why I think the machinery of government piece is a really important litmus test. Is there a real intent here that will be manifest not just by the establishment of this agency in the department, but actually how the rest of the civil service is mandated around this in terms of what it does. So I think that's one thing. I absolutely agree on the point about health and wellbeing boards. We have a new entity coming onto the pitch as well, the health and care partnerships that are part of the legislation. These two things seem potentially complementary and potentially overlapping, and I think they both will require a good deal of OD support to get them into a place where they are more than what some of them are currently, which is just talking shops. And I think the other thing I just would throw in is really reflecting on Maggie's answer just now, there is maybe a case to be made, in fact there's more than a case to be made, that there should be a positive duty on all public bodies to have this health in all policy piece, to be able to evidence that they are doing that. And I think that the influence they are themselves as corporate bodies having on their partners. In other words, how do you maximize the reach of this? So I think there is something about not having just a duty built into your licensing regime in a local authority, but actually a more general duty on all public bodies.
Thank you, Paul. And Maggie, lastly, you.
Thank you, and some excellent points there, colleagues. Thank you. If you'd asked me this question last August, I was not optimistic. You know, to chop the head off your chief executive of your leading public health agency and disestablish it did not sound very optimistic for public health. But I think a lot has happened in the last 9 months. I think public health is centre stage, so of course we have to be optimistic about that. And I think we have doubled the professional public health people within the Public Health England system since the pandemic started, because those cuts have you know, we weren't prepared, and those cuts have made life very difficult. So we are in a better place. The real issue will be to remain optimistic. Can we continue in that place? Could we perhaps have 1 or 2 of those billions that Test and Trace have got to spend on local public health? And could we ensure that the makeup of these agencies, particularly the new Health Security Agency, has the prominence of the specialist public health workforce, and they're not overshadowed by, you know, 10,000 people coming from Test and Trace. I think that's really important, because we want to ensure that we have a good, rounded system for health protection, not just one based on one incommunicable disease. Well, in fact, it's not all the coronaviruses, it's just one coronavirus. So those things are really important to me, for me to remain optimistic, and we need to see those resources and the delivery systems come to light. It's not clear enough yet to give me total optimism, but I can sit here and say that all the functions of public health have been re-provided. All the functions of public health have been re-provided. I didn't think that would happen last August. So I testimony, Deborah, to you, David, Paul, Hazel, and all the colleagues that have helped us lobby for public health. We're extremely grateful. Thank you.
Thanks very much, Maggie. And can I ask the team to bring up my last slide? We're actually out of time already, so I'll be as quick as possible. First of all, to thank the speakers who've been brilliant. I've learned so much. And secondly, to say thank you for all the participants and all the comments and questions you've put in. And please do come back if there's anything else you want to tell us. There will be a survey going out asking for your comments on the webinar. It would be really helpful if people responded, because we do take it into account in trying to make sure that any future events we run take into account what worked and what didn't. Next steps, the output from this event, we are going to summarise the key points from the speakers and the audience and our own thinking, and send something round to everyone the week after Easter, we hope. Although this has been so rich, it will take longer than I originally hoped, I think, to really begin to think it all through carefully. And please do respond to the DHSC request to help us design a system for the future. The deadline is very tight, 26th of April, via the online form. Someone asked in questions whether that was for the Office of Health Promotion as well as for what's now being known as UXA, and yes, the answer is yes. So, you know, it's tight. Then I wanted to just remind you of the timeline set out in the policy note for the operational changes. In the spring, there will be confirmation of the future destination of all services and functions. By the summer, there will be the development of what Cathy Morgan in PHE called the wiring diagram for UK HCSA and the OHP. In the autumn, UXA will be fully operational, OHP will be established, and the transfer of staff will be complete. Then I wanted to talk a bit about the timeline for strategy, because the policy note did talk about further detail on our public health strategy building on the green paper. And, you know, what does that mean? Well, since the green paper, we haven't really had much, but there was the Tackling Obesity strategy published in July 2020. Well, what does all the new arrangements mean for obesity? Then just yesterday, the COVID-19 Mental Health and Wellbeing Recovery Action Plan was published, and that's well worth reading. There's lots of mention of public health in there and the role of local government. And certainly when we've talked to colleagues in mental health, they are very concerned to see the development of a proper public mental health function. And I think COVID has really thrown a light on that. And in July, we still hope to see the new tobacco control plan to deliver the green paper ambition for a smoke-free 2030. But I think, as Hazel said in her presentation, we are a bit the cart before the horse, because you would normally expect to see the structures built on what you're trying to deliver, when actually we're doing it a bit the other way around. And I think it's all our job to make clear what we want to see delivered in terms of the outcomes for public health, to truly transform public health going forwards. So thanks everyone, and have a great Easter. Bye.